So this chart, what we have given you, will help you to go through your practicals. Please make a chart of it and please do see it daily. Okay. So if you can do this, this will help you. Another point what we have taught you is for meiosis, 3 C's. What we need to remember: cholinergic system acts on which group of muscles? Circularly placed constrictor pupillae muscles, and it can cause constriction of the pupil and it will lead to meiosis. Start it. Keep the backs down. So this is one more repetition for you. So central nervous system, we have this brain spinal cord. In the peripheral nervous system, we have the autonomic nervous system. So then, after that, we have the enteric nervous system. So here, one more important chart. Okay, so central nervous system, peripheral nervous system, we have this cranial nerves and spinal nerves, sensory part and the visceral part. In the motor efferent division, we have this visceral motor where our parasympathetic and sympathetic divisions working together. Parasympathetic is nothing but a cholinergic system and sympathetic is nothing but our adrenergic system. So this diagram, yesterday, I mean to say in the practicals which your seniors have taken, so most of them didn't go till this question. They belong in the earlier part. They didn't know what is mydriasis, they were not able to answer the meiosis. What is direct, what is indirect? If they answer, then only the next questions about this autonomic nervous system will be asked. Okay? Remember, acetylcholine is the preganglionic neurotransmitter in both sympathetic system and the parasympathetic system. Okay? So, this is the diagram here. You can see acetylcholine. In the somatic nervous system, acetylcholine is there. That you can remember. Most of the people are failing here. Okay, parasympathetic system, both preganglionic and postganglionic is the red one, that is acetylcholine. But in sympathetic system, you can see the red one here, that is acetylcholine. But in the postganglionic side, we have norepinephrine or the adrenergic system of the drugs. Okay. So this diagram you might be knowing what the sympathetic system does to the body. Today it is important because in a different context, today we are learning about the anticholinergic drugs. Okay? Anticholinergic drugs act in somewhat similar fashion as our sympathetic system will do. Okay? So you can see here on the board we have this anticholinergic drugs here. Okay? Anticholinergic drugs are causing mydriasis, which is indirect, and it is also causing cycloplegia. Okay, here is what we are seeing. Okay, mydriasis or the dilation of the pupil, it occurs with the parasympatholytic agents or the anticholinergic drugs. Okay, so here we have this increased salivation, but in case of parasympathetic drugs, we have decreased salivation. Okay, so rather than the cholinergic system, anticholinergic system have more uses. Okay, how it is that we are seeing here. Okay, so for mydriasis and meiosis, where we need the use alternate mydriasis and meiosis, where do we do that? In refractory areas, we do only mydriasis. Ideal psychiatrists, okay? When there is a benefiting IMGB, we need to do alternating mydriasis and meiosis so that we can prevent the adhesions. Okay, that's where we can use the parasympathetic pupil constriction. Drug is pilocarpine or paltusotine. Okay, pilocarpine. Then dilation of the pupil, we can use a shorter acting alternative, that is parasympathomimetics. We have propylamide, cyclopentolate. Okay. Then decrease in the salivation, Then increase in the respiratory rate here. Rather than increasing the respiratory rate, the parasympatholytic agents are involved in bronchodilation. Okay, we have Atropine bromide and Atropine bromide, which is acting at this site, and these are the lifeline drugs for the asthmatics and chronic obstructive pulmonary disease (COPD). Okay. So that's it. Then we have decreasing the heart rate and increasing the heart rate. So atropine can be given in case where the patient is having maybe syncopal attack or maybe hypovolemic shock. You can give a shot of atropine. Okay, it forms a basic part of the resuscitation. Okay, so that we can increase the heart rate. Then dilate the blood vessel in parasympatholytic we can get the constriction. Inhibits the digestive process, so blood circulation will be increased in other sites. Relaxes the bladder muscles, that is very important. So frequency, hesitancy, urgency. Have you heard this term? Frequency, hesitancy, urgency. These are the primary symptoms in case of renal stones, urinary tract infection, and also in case of renal stones. So it can, then we have the action, that is inhibition of defecation. Okay, so parasympathomimetic drugs, this is just a summarization of what the previous slide showed. Okay, both acetylcholine, preganglionic and postganglionic. Okay, except for apocrine glands. Okay, then cholinergic fibers. The basic common question will be where are cholinergic fibers or cholinergic receptors present? Okay, or where acetylcholine is active. Okay, it is also multimotor neurons or preganglionic fibers and postganglionic parasympathetic fibers. These three things you can permit, they will go to further higher question. You will be posting yourself to more than 60% of the marks. Then, okay, so parasympathetic system, 75% of all the parasympathetic are the wakers. So you know this. So receptors. So where these receptors are present? This is very common question. Okay. So make a chart of this. Okay, where this nicotinic receptors, where this muscarinic receptors are there. Okay. So in this case, in this chart, I need you to understand that the drugs which we are studying today are anti-muscarinic agents rather than the anticholinergic system. I am using a new term, anti-muscarinic system, because the drugs what we are using here are anti-muscarinic. That means they can act on only, they can inhibit the action of acetylcholine only on these M1 and M5 receptors. Okay, there are other drugs which can act as this. Agonist here, agonist, antagonist here will be at NN, ganglion blocker, parasympathomimetic, all these things. Okay, neuromuscular, autonomic ganglion. Okay, NN here will be parasympathomimetic, guanidine, all these things. At this junction, it will be skeletal muscle relaxants. Okay, the nicotinic the NM receptor, neuromuscular junction. The drugs which can inhibit the action of acetylcholine at this site are the skeletal muscle relaxants. What are those? Non-depolarizing, depolarizing, detuberculizing, attractive agents, all these things. Okay, that whole classification is there. In your practicals, there is a particular question regarding this. What the question which was asked was which drugs can block this action. Okay, we have a graded dose response curve. Do you remember graded dose response curve? Okay, so after that we have a chart where the action of this acetylcholine is blocked by detuberculin. Okay. Yes, explain me what I am trying to explain. Yes, stand up, both of you. Stand up. If you are not able to explain, walk out. Fast. Both of you. I don't have time for you people. Do you need to pull up? Go. If you can explain, stay back. Stand. Yourself. Walk out. Take your luggage and go, please. why you are using D-butyrate? Why not atropine in this condition? Okay. So the answer here should be very clear. The drugs which are used as anticholinergic or antimuscarinic, what we are telling are the atropine and atropine, homotropine, all these group of drugs. Okay. All these group of drugs which can act at this muscarinic receptors, not at this neuromuscular junction. That's why this atropine, homotropine and the related group of drugs will not be able to block this. Okay, so it is very simple and none of them answer this question. So it is a simple concept. Okay, just remember that. Okay, sorry for this, but this can explain you where M1, M2 and M3 receptors are present. Okay, M1 you need to remember ganglia, gastric glands and CNS. M2 cardiac, SA node and AV node you need to remember. M3 for glands. Okay, so the agonist here is the oxytocin or the M1, and M2 we have methacholine and M3 we have bethanol. So antagonists here are parasympathomimetic, tiloneuropine. Here we have tropitramine, tolterodine and diphenhydramine, most commonly used by urologists, like something like bread and butter for the urologist. So classification of the drugs here, these are rather anti-muscarinic agents rather than anticholinergic agents. Okay, here we have the natural alkaloids, that is atropine, hyoscine, scopolamine. Then we have the semi-synthetic drugs, that is mydriatics, homotropine, most commonly used for the refractory error and also for the iron cyclic condition. Anti-asthmatic, we have ipratropium, tiotropium, bromide. Okay, so ipratropium bromide, tiotropium bromide. These are the drugs which are used in asthma and COPD. Okay, GI spasmolytics, we have iodine bromide. Most commonly it finds its use in case of mountain sickness and also for travelers. We have the calcium patch. Then you might be knowing in case of this recent terrorist attack and all, what they do? They use truth serum. Have you heard of this truth serum? So scopolamine is one more truth serum. So synthetic compounds we have this mydriatic, tropicamide and cyclopentolate. We are using them as the alternatives for this homotropin or for mydriatic test. So GI spasmolytics we have oxycodone, clidinium. So clidinium, it is the most commonly used. The popular trade name is the normaxin, where it is used for the diarrhea which is associated, like patient comes to a typical symptom in amoebiasis. As soon as I take food, I have the urge to go for defecation. Okay, this is the most popular, and it is also seen with the irritable bowel syndrome. In both these cases, we use the combination is clidinium. So then we have this tertiary amines, that is dicyclomine, most commonly used in case of spasmolytic conditions or any over-the-counter drug, dicyclomine. Okay, so then we have this anti-ulcer, parasympathomimetic and tiloneuropine. We need to remember parasympathomimetic and tiloneuropine are now replaced by the H2 antagonists, that is ranitidine and cimetidine. They are better agents, but still you need to remember the drugs which can be used as for GI protection, that is anti-ulcer agents in GI, that is parasympathomimetic and tiloneuropine. Vasopressor selective, we have flavonoid, oxytocin, tolterodine. These are again the most common drugs for the bladder relaxation. Anti-Parkinsonian drugs, that is central muscarinic cholinergics. We have benzoxazole, benztropine, piperidine, and this is other name for benzoxazole is tricyclidine. We have benztropine and piperidine. So these are the drugs you need to remember in this group. So this is the diagram which was shown in the previous class. So here I am trying to show you the acetylcholine synthesis inhibitors. We have initial choline incorporation, that is hemicholine, which can block that. Then vesicular incorporation of the acetylcholine, we have vesemicol. Then release of this acetylcholine is blocked by the botulinum toxin. then our atropine is acting as a competitive inhibitor at the receptor site. That means if the acetylcholine levels can be increased, means the atropine action can be surmounted. That's it. So atropine, it is a belladonna alkaloid. Okay. So has high affinity for muscarinic receptors, competitive inhibitor, preventing acetylcholine from binding to its site. So atropine, you need to remember, atropine, it is obtained from this atropine, belladonna. So belladonna, do you know some history about it? Belladonna stands for beautiful, good-looking lady. So previously, what they used to do, ladies, they wanted to impress upon the other part. So what they used to do, they wanted their pupils to be dilated. So those ladies who had their pupils dilated found to be more beautiful. So that's why they used to consume this, not apply in the eyes. They used to consume this plant. Okay, that's why it got its name. So anticholinergic drugs. This definition, if you can remember, it will help you in the exams. Okay, so these drugs agents block the muscarinic receptors and inhibit the muscarinic function, and they are useful in different clinical conditions. Here they need to remember they have no action on the skeletal neuromuscular junction or autonomic ganglia because they do not block the nicotinic receptors. So atropine, what is its action on the heart? So I told it can be a part of this emergency kit where you can increase the heart rate. Okay, so that I need to tell about this chronotropic and dronotropic effect at the moderate dose. Okay, so at moderate dose, M2 receptors on the post-junctional SANK, cerebrum and AVN. Okay, then escapes the heart from its inhibition of the vagus. Okay, vagus acetylcholine, its action is inhibited. Then what we can get, tachycardia and unopposed adrenergic action. That is chronotropic and dronotropic action we are getting. That's why it forms a part of our emergency kit. At low doses, what can happen? M receptors of the cholinergic nerves, we have something called as autoreceptors, which I tried to explain in the previous class. You might be remembering. Okay, autoreceptors. If these autoreceptors are there on the prejunctional side, you can see here there are some acetylcholine autoreceptors. So it is auto-regulation of this. Here you can stimulate this autoreceptors. What can happen? The acetylcholine release can be inhibited. Once this acetylcholine release is inhibited, there can be decrease in the action of acetylcholine. Okay, that inhibitory action is removed means there will be cholinergic action. This auto-inhibitory action can be like acetylcholine, which is releasing this presynaptic inhibitor. Okay, it is something like a auto-regulated system. What is happening? The acetylcholine, which is reaching the autoreceptor, is inhibited means the prejunctional ganglion will think that okay, acetylcholine is not synthesized in enough quantity, I need to release more. Something like that will happen, and here there can be more cholinergic, more acetylcholine is released, and there can be bradycardia. So this part you learn. Then at toxic doses, what can happen? M3 receptors at the endothelium, they can cause this release. Okay, endo release is blocked, so do not relax. Prevention of the cholinergic mediated dilation. All these things will be there. On blood pressure. Okay, this is the graph you have in your practicals. Okay, what is the action of acetylcholine on the heart? What happens if the acetylcholine is acting on the muscarinic receptor, and what happens if it is acting on the nicotinic receptors? Okay, so here the answer is blood pressure, tachycardia. How do you block the tachycardia? You can see here. Okay, then vasomotor center stimulation, that is CNS mediated nicotinic action. Okay, tends to increase the blood pressure, and the histamine release and direct vasodilation tends to decrease the blood pressure. So you can go for this. Here you can see what is happening here. Atropine, you can drop the muscarinic action but not the nicotinic action. Okay, so blood pressure you can see at the initial phase when we are given this acetylcholine, there will be decrease in the blood pressure because vagal mediated action. Then again acetylcholine, we have increased the dose, so the response has also increased. The response increase means decrease in the blood pressure. Acetylcholine, direct action, decrease in the blood pressure. Then we are giving atropine. Okay, atropine is a drug which can competitively block this acetylcholine. What can happen? There will be no, once you are given atropine, there will be muscarinic receptor blockade. Even though you give acetylcholine, there will be no response because competitive inhibition. Then, if you can increase the dose of this acetylcholine, such as, like, you can see it is a microgram here. MCG is microgram. Here we are given more than 1000 times more dose, that is 105 milligram. Okay, so what can happen now? Muscarinic receptor are blocked, but when acetylcholine levels are increased, there can be nicotinic action. Based on this nicotinic action, vasomotor center activation, there can be increase in the blood pressure. As simple as it. Okay. Okay, this is it. Muscarinic effect first, then we have this nicotinic action. So, acetylcholine on the CNS. Sorry, atropine on the CNS. So, most commonly where we use this atropine for, where do you use this atropine? The drug of choice. Atropine is the drug of choice for which poisoning? Organophosphorus poisoning. Okay? This organophosphorus poisoning, what can happen is the setup in which the atropine is given, where the atropine is given continuously. It is a complete bottle containing some 100 ml bottle, where we can give every 10 minutes till the signs of atropinization are there. We are giving 2 milligram or 2 ml of this atropine. Okay. So this 2 ml of atropine will be given till the signs of atropinization are there. The signs of atropinization are mid-reaxis. Okay. Intravenously when we are giving, it can cause mid-reaxis. Okay. So that will be the endpoint for our stopping of this atropine. If this is not done, somehow the dose is increased or excessive installation is there, then there can be CNS toxicity. I have seen in my college where I was a UG, we are in our medicine postings, the person had gone missing. He has stripped the cannula, was missing. So later we found him in the rooftop, and he was roaming here and there like that. And second instance, when I was doing my house surgeonship, that one more person, similar problem. There was no, actually it's a government hospital. It was a government hospital. So the person has gone to the rooftop, climbed, he jumped from the top. He died on the spot. So rather than the acetylcholine or the organophosphorus toxicity, the person can go for hallucination and delirium in case of atropine toxicity and can die. So that's why we have the term for this atropine, mad as hatters. Mad as hatters, that is the term which is used for atropine action on CNS. Okay, so it has overall stimulation action. Its stimulation effects are not appreciable at low doses, but at high doses, it can cause this excitation, restlessness, disorientation, hallucination. Okay, there can be respiratory depression and coma also. So that is the thing. On medullary centers, it has vagal, respiratory and vascular centers. It has suppressive action. Okay, it can suppress the cholinergic activity in the basal ganglia also. Here, in case of Parkinsonism, we can use this drug. Okay, so in case of Parkinsonism, the drugs used for Parkinsonism, anyone? Yes. We are increasing the dopamine? Sure? Yes. So we are trying to increase the dopamine here. Why we are using this anticholinergic drug first? Yes? So dopamine, the normal amount of dopamine in the CNS can keep check on the central cholinergic activity. Something like husband and wife. Okay? If the wife is in home, husband will be in check. Okay, something like that. And if this wife has gone out and the husband is staying in the home alone, he will have all merry-making parties. Something like that. Okay? So if the dopamine D is not there in the CNS at adequate levels, okay, what can happen? I have just given one example. Okay, here we have this action. If the cholinergic activity will be more in case of this drug-induced Parkinsonism. Okay, so drug-induced Parkinsonism, we are using this drug. So high doses, there will be cortical excitation, all these things are there. So this is one important diagram. Again, I am sorry to tell that more than 70% of the students fail to answer what is direct mydriasis, which group of models are involved. Okay, so just try to put this chart in your room. Okay, so here what we are seeing, this is the normal thing. Here we are seeing mydriasis. Mydriasis can be by two groups of drugs. What are the two groups? Anticholinergic drugs and adrenergic drugs. Yes, first group. Mydriasis is by. No voice is coming from that. And mydriasis can be caused by louder, adrenergic and anticholinergic. Yes. Meiosis can be caused by and anti-adrenergic. In the exams, we are not giving this anti-adrenergic. Simple, only 3 drugs are there. Okay? Don't confuse in the exams. Okay? Simple, there is direct mydriasis, there is indirect mydriasis. What is it? We have already seen it on the chart there. So here we are telling that the cyclopedia may last for 7 to 10 days. Is it, can we use this drug then on the patients? No, we are never using it. Why? What are the alternatives we have? The shorter acting mediated agents are, we spoke about it in the previous slides. What are the Comodopin, cyclopentolate, tropicamide. Okay? 3 alternative mydriatics to avoid this cumbersome 7 to 10 days mydriasis is these 3 drugs. So we are testing this on rabbits. Have you seen? It was not shown to you in the practicals, but your seniors witnessed it. All the seniors, most, I think from your batch we have not done that. Why we are doing that on rabbits? Do we need to keep this animal blind for a long time? Is it human? See, rabbits have a special property. They have the enzyme to lyse this atropine. Okay, so even if you have used this drug, atropine itself, not the container, still atropine can be metabolized. Okay, that's the point. So atropine on smooth muscles, this you already know. This is, I go faster, or visual smooth muscles and parasympathetic innervations are relaxed by sympathetic blockade. If GI tone is reduced, there can be constipation also. In case of atropine, in case of arteriovascular poisoning, one more thing you can see. For example, you have a doubt that the person has taken maybe consumed or not consumed, then they saw it by vomiting and also by defecation. This is typical of arteriovascular poisoning. Sweating will be there, defecation will be there, and vomiting will be there. Drenched in their own secretions. That term you can use. Okay. So that's why atropine can be helpful in all these conditions. It decreases the secretion, it decreases the vomiting there, and also no defecation. So you can constrict those things. So spasm and constipation may occur. So peristalsis is incompletely suppressed. Still, it is helpful. So this is the atropine plant. Okay, so this focus on keeping it because in your spotters we are keeping them. That's why. So atropine action on smooth muscles. What can happen? Causes bronchodilation. What are the drugs we are using here? Drugs used in COPD and bronchial asthma. Ipratropium bromide, tiotropium bromide. Salbutamol, not from our class. It is belongs to adrenergic system. We are dealing today with anticholinergic system. So, inflammatory mediators, histamine, prostaglandin, it is released. So, we know that due to histamine release, there can be vasodilatation and we can decrease the blood pressure. So, atropine is the action that is there. Then, urinary retention in older men. Okay. So, we are using the continuous here. What are the drugs we are using? Flavoxylate, oxybutynin are the drugs which are used for this property. So, then